Hello, everyone. Welcome to today's DDU meeting. My name is Rishi. I'm one of the Echo Fellows working at Nepean along with Sam. And joining with me is Haven, is my colleague who is also doing DDU with me. Sitting behind me is Anju, is one of our senior sonographers who will be joining us as well. So what we'll be discussing today is about pulmonary vein assessment. What will be the general outline today will be, we'll be going briefly through, quickly try to, within 30 minutes, to go through the relevant anatomy and some Doppler waveforms, and then we will practice some cases. I have a few interesting cases to go through, and the last one was given just today morning by the co-director of imaging cardiology today. So that'll be good to go. So pulmonary veins, they are hard to find, but when you find them, you definitely get a lot from them. There are many reasons to practice them. Sam is very fond of it. He says pulmonary veins, it's very hard to get dodgy numbers from the dodgy information from pulmonary veins. It's very hard to fake, is what he says. They can help you with diagnosing congenital and acquired heart diseases, LV diastolic dysfunction, estimation of the left atrial filling pressures, estimation of the LA functions, and estimation of mitral regurgitation severity, as well as distinguishing between constrictive versus restrictive cardiomyopathy. In an ideal world, there are usually 4 pulmonary veins in all of us, and each open via separate ostia into the left atrium. The two on the left upper and the left lower. The left upper drains from the left upper and the middle lobe, lingular lobes, and the left lower pulmonary vein drains from the left lower pulmonary lobe. Similarly to the right upper pulmonary vein drains from the right upper and middle pulmonary lobes, and the right lower pulmonary veins drains from the right lower pulmonary lobes. However, the real world anatomy looks like this. There is a lot of variations in the number of pulmonary veins and the way they joined. And this is something important for us to keep in mind. As you can see over here, this is the usual normal anatomy, which is usually present in around 70% of people. The most common variation happens in around the left pulmonary veins. Many times they join via a common left pulmonary vein, and sometimes that common left pulmonary vein is a bit elongated. So you may only see one vein on the left side, which could be a common one. It's important when we are looking and chasing for left and 2 left pulmonary veins. This happens more in 20% of patients. In the rest, 20 to 30% of patients, we have accessory pulmonary veins. Mostly they happen on the right side. As you can see, there is a right pulmonary vein here, right middle pulmonary vein, which would be draining from the right middle lobe of the lungs. Similarly, there are 2 here and there's 1, 3 here. Now, these things are very important. This anatomy is very important for people who do EP studies or going to do imaging for pulmonary vein isolation. Having said that, I'm not an expert in doing imaging for EP studies, but they also look into CT anatomy and MR anatomy along with the TE anatomy. The pulmonary veins are the shortest of the great vessels, and where they join, as you can see over here, there are 4 pulmonary veins. The point where they join is the ostia, and they have a myocardial sleeve, which is macroscopically, there is no distinction between the, you cannot distinguish from the top or inside where pulmonary veins end and the left atrium begins. There is a myocardial cuff. And the reason why it is important is because these are the places which are the sites for ectopic activity and the sites for atrial fibrillation and A-flutter. And these are the things which are they target during pulmonary vein isolation techniques. The induced cryoablation or radiofrequency ablation burn the area, induce scarring, which will in turn help us to prevent those ectopic conductions to go into the left atrium. What is also one thing they use is also the tributaries and what's the minimum distance between the left atrial ostial opening and the last pulmonary vein tributary. This is the safety margin which they have. If at all, this is where sometimes they insert the balloon or the catheter and they do this cryoablation or radiofrequency ablation. If at all the small tributary veins get occluded or destroyed, there's a high likelihood that they'll develop pulmonary vein stenosis, and the area which they drain, they won't be draining, and the patient will end up in more pulmonary edema or shortness of breath. This is how the EP studies, how they go through the vein, do a transeptal puncture, and do a figure of 8, ablations. And this is how they prevent those ectopic beats from coming from this myocardial sleeve and extending into the entire left atrium. This, while doing those ablation procedures, is also important to get to know what in details what's the anatomy of the pulmonary veins are. Pulmonary veins being extracardiac structures, they are not easy to fully delineate just via ATE, and hence the need for contrast CT scans just to delineate the anatomy thoroughly. These are also important in patients with post-lung transplant developing pulmonary vein stenosis or other congenital variants, or just to see the number as well as the patency of these pulmonary veins. Catheter angiography is done by cardiologists also in relation to this, just to delineate the pulmonary anatomy a bit better and the number of pulmonary veins and where they will be going into it. And this is the 3D picture of the pulmonary veins. As you can see, this is the mitral valve. We are looking from the LA down into the LV. The left atrial appendage you can see at 4 o'clock position of the mitral valve. Left upper and left lower pulmonary veins are situated posterior to it. And this is the cut section, which shows that this is the LA and the LV with the mitral valve opening here. The positions of the pulmonary veins will be right at the back. So that's if you see, this is my heart model over here. And you can see the pulmonary veins, which are here, and they are joining the 4 of them. And when I do the cross section from here, so pulmonary veins will be coming right from the top. And this is what this image shows over here. There are various challenges when trying to track pulmonary veins, especially in transthoracic echo. But transthoracic echo being the most widely used is essential for us to know how to find and use pulmonary veins in transthoracic echo. The main challenge is the far field location. As you can see, the probe is positioned over here at the apex, and the pulmonary veins at the farthest. And hence, there is a dropout of echo shadows, and there's a lot of fudging which happens. There are also extracardiac structures, which doesn't help. Moreover, in ICU patients, most of our patients have chronic lung disease, prosthetic valves. Imagine there is a prosthetic mitral valve. There'll be a lot of artifacts which will be obscuring these pulmonary veins. Many of our ICU patients are, mechanically ventilated, and that the positioning is also not the best. In addition to that, people are obese, and they have sometimes severe LA and LV enlargement, which makes finding the pulmonary veins a bit challenging. In pulmonary waveforms, while doing a pulse wave Doppler, the A waves are also a bit difficult to record, mainly because of the low velocities, which you can see, and the lot of motion artifacts which you get from the left atrium. It's a very low velocity signal, and often it's very hard to find. And when we get it, it's very, very, its value is what is its weight in gold. Where to look for in a transthoracic echo? Now, the most useful rule I found was from a YouTube video I saw for pediatric patients. The essential message in that was the left pulmonary veins are visualized better from parasternal views, be it parasternal long axis or a parasternal short axis. Sometimes the apical 3-chamber is also equivalent of the parasternal long axis, so we can see the left pulmonary veins better in that. The right pulmonary veins, as you can see, they are better visualized from the apical views, because they join just close to the interatrial septum, and that is where the probe, the alignment with our echo probe is the best. The right upper pulmonary vein is related to the superior vena cava, and right lower pulmonary vein is related to the inferior vena cava, something we need to keep in mind while doing neonatal echocardiography. The flow in upper pulmonary veins is downwards and vice versa for lower ones. We'll see some demonstrations of these rules in the coming slides here. Now, as you can see here, these are the two apical views. There's a 4-chamber view and the 5-chamber view. The pulmonary veins, you can see the pulmonary blood flow coming into the left atrium and in both images, but we are looking at right pulmonary veins, but which one is which? Looking at the transthoracic views, we usually look at right lower pulmonary veins. While angling the probe, fanning the probe upwards towards the aortic valve, the right upper pulmonary veins comes into picture. Now, how do I know it? Because of concomitant fluoroscopy studies, which they have seen along with echocardiography, showing that in apical 5-chamber is the right upper pulmonary vein, which is mostly seen. Similarly, in parasternal long axis views or apical 3-chamber views, we can see the left-sided veins as per the rules which we mentioned. And the fourth rule was if the blood flow is coming from bottom to up, it is the right lower pulmonary vein. And this is what you can see from here. So the blood flow is red coming into the left atrium that's coming towards the transducer, which means that it's flowing from bottom to up. So here we're looking at the left lower pulmonary vein. Whereas here the blood flow is away from the transducer and is going from top to the bottom. So we are looking at the left upper pulmonary veins. Parasternal short axis views also, again, the left pulmonary veins can be seen. This blood flow is going from towards the transducer, means lower to up. So most likely it is a left lower pulmonary vein. Very rarely in most cases, we cannot see all the 4 pulmonary veins together because they are joining very wide apart and in different planes. Only in children and in very small, thin adults, potentially there is a chance to see all 4 pulmonary veins together. And this is done by a suprasternal view. So this is a cross-section from the suprasternum and a notch, and the probe angling downwards, and it's the short axis view which showing all 4 pulmonary veins. This is useful to know the pulmonary vein anatomy just with a non-invasive imaging, and this is called the crab view. The most common view, however, in transthoracic is only this one. We go for the right upper or lower pulmonary vein, and we get the most bang for buck in interrogating this pulmonary vein because of the fact that the Doppler alignment is the best we can see from the probe. There are various tips to optimize the pulmonary vein trace. However, you can see there are people who have done. There's a question there on the pointer position is towards. This is short axis view, so pointer position could be towards your trachea. In the tips to optimize is we always use the ECG because it's essential to know which phase of the cardiac cycle the blood flow is going in. The angle of the transducer, I try to pan it superiorly towards the aortic valve so can get the right upper pulmonary vein. The tip of the pulse wave should be 2 to 3 millimeters inside the pulmonary vein. The sample gate should be 2 to 3 millimeters, and this pulse wave gate should be at least 0.5 to 2 centimeters, 2 millimeters inside the pulmonary vein. We have to adjust the gain to reduce it to be able to slightly lower velocities around 30 to see the pulmonary veins entering it. To see the respiratory variations, I record the pulmonary vein Doppler tracings at 25 millimeters per second, but for doing other measurements such as ST or a wave reversal, I go for 50 to 100. This is what the trace looks like. From the non-optimized image, this is how the image looks like. And just after optimizing the image a bit better, this is how much better the pulse wave, the pulmonary vein pulse wave Doppler got through. So as you can see, this is well inside the pulmonary vein. The sample gate is around 2 to 3 millimeters wide, and at least a centimeter below the left atrial posterior wall. And the color gain is optimized around between 30 to 35. And you can see the S wave and D wave. A waves, as I said, is not always best seen. There are other images I'll show where the A waves is a bit better. The normal pulmonary vein pulse wave trace is something to worth noting, and the variations of it. Usually that is the normal waveform is, as you can see, the third one from the images on the left. It is usually quadriphasic or triphasic. Quadriphasic waveform gives us the best of information, but that is more something which is more amenable to be seen in transesophageal echocardiography than in transthoracic. In transthoracic, most of them, these S1, S2 waveforms fuse and they form a triphasic waveform, and the S and D and a reversal. The quadriphasic waveforms are, they are pulsatile and the blood flow is bidirectional. They're influenced by the cardiac function and the LLA pressure, and to a lesser extent by the, from the SVC and IVC blood flow and the respiratory cycles with that. There are 4 distinct Doppler waveforms. The S1 and S2 are, the first 2 anterograde waveforms. They're occurring in early systole and mid to late systole. The S1 and S2 waveforms, they occur in the ventricular systole, and that's why the S form letter is there, and they correspond to the reservoir function of the left atrium and correspond to the X descent on the LA pressure reading. Okay, this descent. The diastolic waveform occurs in the ventricular diastole and hence the D. And in diastole, it corresponds to the mitral inflow velocities, the E and A waveforms. And this corresponds to the conduit function of the LA left atrium. Following the P wave is the A reversal, and this corresponds to the pump function of the left atrium. And this will be something we'll be doing I'll be telling a bit more about it, what's the usual measurements are. Now, in normal healthy adults, more than 40 years, usually the S waveform is less than D waveform. However, in a young, fit person, you still can get the S wave, which is less than the D wave. Okay, as this shown in this figure, where this is just an 18-year-old healthy woman with no structural heart disease. And these are some useful pulmonary vein measurements, which we do in a day-to-day practice. The measurements we do are the peak velocities of the S, D, and the A waveforms, and the A wave duration. Okay. There are 2 other parameters which we can use. That's the deceleration time of the D wave and the systolic fraction, which is basically doing a VTI of the S wave and the D wave, and then dividing it, the VTI of the systole divided by the sum total of the VTIs of the S and D waves. In reality, these are the 2 ones which we commonly use, 3 ones which we commonly use in day-to-day practice, which the sonographers even do it in their practice. In unhealthy adults, less than 40, they can reflect normal left atrial pressure. Usually in an adult, the S wave is more than the D wave, so the S by D ratio is more than 1. And this has an inverse relationship to the left atrial pressure. As the left atrial pressure increases, the S and D becomes less than 1. And this has shown to correlate with higher cardiovascular comorbidities and mortality. The ARA duration correlates with, this duration of the A wave, when you subtract it from the mitral inflow A velocities, if it is more than 30 and combined with a short deceleration time, that is useful as a predictor for diastolic dysfunction. As a thumb rule, this deceleration time of less than 175 correlates with a left atrial pressure of more than 17, and a deceleration time of, say, more than 275 correlates with a left atrial pressure of less than 6, which is normal. A systolic fraction is very interesting because this is highly predictive. If it is more than 55%, it is highly predictive of normal left atrial pressure. The factors which are influencing the pulmonary vein, the waveforms, is worth remembering that all these S waves, D and AR reversal waveforms, they reflect the LA filling throughout the cardiac cycle. Whereas the D and the A waveforms, because they correspond to the E waves in the mitral inflow happening only in diastole, they are influenced by the LV filling during the diastole. So what are the factors which are influencing the various waveforms which we have seen? Now the S1 corresponds to the LA, the early filling phase of the left atrium, and they're decreased by left atrial dysfunction. The S2 waveform is increased when there is increased contractility using inotropes, contractility of the LV. The S2 waveforms can increase. It is decreased, however, when the left atrial pressures increase and also suppressed by mitral regurgitation. The D waveform is decreased by impaired relaxation. This is a marker of diastolic dysfunction. The atrial reversal waveform, these are increased when there is increased contractility of the left atrium, but when the left atrium becomes dilated stiff, this wave disappears or becomes less. The pulmonary vein flow patterns are interesting to note. Now, this is a waveform where the S and D is less than the D, so SD ratio is less than 1, and there is no A waves. That signifies the patient could be in atrial fibrillation. This patient could be a normal, young, healthy individual, or they can reflect for higher left atrial pressures in old age. This is also reflective of moderate to severe MR as well, and also a parameter which we can see in patients with cardiac amyloidosis who have restricted cardiomyopathy. Prominent A wave is seen in patients with diastolic dysfunction, short PR interval, or intra-atrial conduction delay. Now, this systolic reversal is interesting to note, something which we seek actively in very often in patients when we are doing estimating severity, which is a very common indication for doing TOEs in patients with MR. It's important to talk a little bit about it. This is not very sensitive, but it is very specific of severe MR. It's also worth noting that one can have severe MR in absence of systolic reversal. However, if you are able to show a systolic reversal in 2 out of 4 pulmonary veins, there's much better argument in favor for the MR to be severe. Also, it is worth noting that the right upper pulmonary veins are likely to exhibit the reversal bit more compared to the left one, mainly because of the way they enter the left atrium and the way they're angulated. So very often when you have a jet which is anteriorly directed or even centrally directed, you are still going to get a reversal in the right upper pulmonary veins. Early systolic reversal, which rarely seen, we see in clinical practice in our ICU patients, in junctional rhythm, medioventricular rhythm, in patients with large ASD. Most of these if there is a left to right shunt, the left atrial blood flow is directly shunted into the right, and you can only get a single forward wave motion, as you can see. Prolonged D wave is something very characteristic of mitral stenosis. This is where you will get a very prolonged deceleration time, and the slope is very prolonged. The high velocities in S and D wave is interesting to note. And this is where you get very high velocities of close to 1 to 2 meters per second. And this is rarely seen, but it is very important to know why they are happening and to interrogate a bit more. In patients with pulmonary stenosis, where there is a high likelihood that the velocities will be high, or vice versa. If I phrase it a different way, if the velocities are high, there's high likelihood of us finding a stenosis. Of course, we need other imagings, but this is the echo or hemodynamic equivalent of how the blood is flowing at a very rapid rate and with the high velocities there. The stenosis is, if there is no stenosis, there could be any thrombus, is like we see in patients with lung transplants who have this pulmonary vein anastomosis, and if they're not, when they're retrieved and all these things are cleaned up, the vessels If they're not flushed properly, if there's a small thrombus or a suture, you develop pulmonary vein stenosis and you get pulmonary waveforms. It is usually diagnosed intra, but I've seen a patients coming through ICU post-op with pulmonary vein stenosis secondary to pulmonary vein thrombosis. And that patient developed flow rate pulmonary edema with just serum coming out of the ET tube. Had to go back to the theaters, they had to reopen the heart and to redo those anastomosis again. Pulmonary vein stenosis, which was rare before, but now it is more and more common because of this, increase in the number of cases where the pulmonary vein isolations are being done. They heal by scarring. More often they're okay, but sometimes they go, the scarring goes overboard and the patient lands up in trouble and develops pulmonary vein stenosis. Usually the pulmonary vein, if their ballpark figure is more than 0.5 centimeters in diameter or more, that's fine. Less than that, you land up in trouble. The patient starts developing shortness of breath. And that's something we should interrogate in patients who come to us to ICU, patients who have pulmonary vein ablations in the past or have lung transplant history, just to keep these waveforms in mind. That could be some of the reasons why the patient could be in pulmonary edema or could be short of breath. It is also important to distinguish between constrictive pericarditis and restrictive cardiomyopathy. A combination of the S and D waveforms of more than 0.65 and coupled with a respiratory variations of more than 40% in the D wave velocities from expiration to inspiration distinguishes the restrictive pericarditis from this restrictive pericarditis from the constrictive pericarditis. On the right, what you can see is this is the restrictive pericarditis where you get like a pattern of diastolic dysfunction and you get a complete suppression of the S wave, which we can see there's a big SD reversal. S and D are still suppressed in cases with tamponade or constrictive pericarditis. But the predominant pattern is this phasic variations of this during respiration, which you will find, because the preload is very much dependent on your phasic respiratory variations. So let's do a case. Are there any volunteers on this one? Maybe see only Drew there. Sorry, Drew.
Yep.
It's very too easy for you.
Yeah, right.
Right.
Hypoxia, respiratory failure, IVDU, 25. Yep.
Okay, so the main thing is we want to know what's the cause of hypoxia in this patient. Yes, Drew.
Yep. Okay, so hypoxic respiratory failure, IVDU. My illness script is thinking towards endocarditis and pulmonary edema. Obviously the differentials could be far broader than that, but that's what's coming to mind. On the left, you're showing me a isolated lung ultrasound. Usually I zoom in, but the pleural line is mobile and below is the B line pathology. Do you want me to talk about the other one?
Yeah.
And then on the right side, you've got a left ventricular function that is preserved with a posteriorly directed eccentric mitral regurgitation that likely shows flow reversal as well. Right side function is intact. Size and function is intact.
Right. And what are these waveforms?
The E wave velocity shows a EA. Given the tachycardia, the E and the A are fused. I think you're probably calculating the left atrial pressures. So in the setting of severe MR and reduced LV function, you could use the EDE prime. I think in preserved LV function, we can't. But taking that into consideration, the septal E is normal and the EDE septal is within that gray zone. I guess gray zone. The TRV max is 3.69, which is above 2.8, which is in keeping with high left atrial pressures in the absence of any chronic lung disease or lung pathology.
Absolutely, brilliant. And then the last image for this one.
So you've dropped the baseline and the Nyquist limit to interrogate low flow. You have a colored box over the area of the right upper pulmonary vein. And what you can appreciate is that there is an S and D wave above the baseline. So I think it's S blunting. So S
Yes.
is smaller than the D.
Yep.
Can't appreciate any systolic reversal, although that doesn't exclude severe MR, as you mentioned.
So this is all about the reason for doing this case is just about quick pattern recognition by doing a few things and to see how we can, connect the dots and advocate more towards whether the left atrial pressure, which is something which is clinically relevant to us, which is something we can treat, whether this patient has elevated left atrial pressure or not. So we have a mechanism. There is a effect of raised left atrial pressure in the patient is in pulmonary edema. There is a reason why there will be left atrial pressure elevation. There's a protruding mitral regurgitation jet you can see. This jet is hovering around the posterior wall and almost just reversing around the posterior wall as well. And there are multiple evidence pointing towards there is a high E velocities, which means that the left atrial pressures are very high and the blood is pushing into the left ventricle at a very high rate. The maximum tricuspid regurgitant velocities are high, and there is E by E prime, which correlates with the left atrial pressure. They're also elevated, combined with the pulmonary vein. So this is why Sam says it's very difficult to fudge this data. So it's difficult to have a false positive of pulmonary vein pulse wave Dopplers. So together with this, I would say that this patient has definite evidence of left atrial pressure, and I would diurese this patient. I would treat that this patient has got APO and would diurese this patient. Coming to toe assessment of pulmonary veins, the pulmonary veins are very posterior structures, as you can see in this heart. And the toe probe, the way it enters the esophagus is it sits there in the back of the pulmonary veins and it's closest to it, and we get very good veins. However, it's very rare for us to be able to get all 4 pulmonary veins in the same picture. The reason being, they are not only a bit far apart, as you can see, but they're also entering at different planes. We start the echo assessment, toe assessment of the pulmonary veins by putting the probe in the mid-esophageal position and then doing 2 probe manipulations to reach to where we want to reach. Now, having a look at these images over here, this is the 3D image of it. This is the mitral valve looking from a surgeon's view perspective, looking from the left atrium downwards into the left ventricle. You can see the anterior mitral leaflet, posterior mitral leaflet. The left atrial appendage you can see at 9 o'clock position. So pulmonary veins is somewhere here, superiorly placed, which will be entering around, say, 7 o'clock mark. Okay, and this you can do by a couple of probe manipulations. The probe is somewhere sitting here, so and looking in this direction. So you have to rotate it anti-clockwise as well as move your handle also clockwise, so that with the aim that you are looking more towards this 7 o'clock position over here. The left upper pulmonary veins you can see first, and if you don't change anything but just push in by a centimeter or 2, or within a centimeter, you should be able to see the left lower pulmonary veins. This is again, if we have the patient who has the ideal wall anatomy. Sometimes the patients have different anatomies, they join at different angles. Sometimes they form a single left pulmonary vein. Okay, in that case you can't do much. You just have to make peace with what you get. And this is how the picture looks like. Okay, so what we have done is I was in the 4th chamber. Then I usually use a color box to guide me to see where the pulmonary veins are entering. After I start rotating the probe anti-clockwise and move my handle as well at the same time. I'm looking at the extreme left towards maybe 1 o'clock position if I'm based on how the probe position is. And there you can see my color box guiding the entry of the pulmonary veins into the left atrium. They're always towards the probe. They're very strong highlight in red. Okay. And this is where you can, the one closer to the probe will be the left lower pulmonary vein. One's away from the probe will be the left upper pulmonary vein. Similarly, when you're looking at the right side, right side pulmonary veins are here. I need to rotate it towards clockwise and then look towards extreme right. And I need to look at somewhere around 5 o'clock position over here. And when I looked at, this is the anatomy I'm hoping to get. So this is the mitral valve. This is the left atrium over here. And the right upper and lower pulmonary veins are entering into the left atrium. The way I can see it here is, again, it's a bit more tricky to find. I go into the short axis view of the aortic valve at 45 degrees, then rotate the probe clockwise, looking by meeting my introatrial septum, and then going further right. Okay. And this is where at the top you will get the right upper and lower pulmonary veins. Again, closer to the probe will be the left, right lower, and then right upper. Similar principles apply. You can get the right upper. If you can push the probe in, you can get the right lower. The left pulmonary veins are usually encountered around 110 degrees. The right pulmonary veins are usually encountered around 45 to 60 degrees. But there's no hard and fast rule. You can do some manipulations. Always see the image and don't focus on the just don't be sticky about those angles. So this is the second case, which one do you want to have back? A 72-year-old gentleman with outpatient referral for MR severity, background of ischemic heart disease, multiple stents, mild LV dysfunction, and moderate MR. So mainly the question was this MR severity assessment. Just for the ballpark figure, just tell me visually what it looks like.
I mean, looks like there's a significant, at least a significant MR.
Yep.
It's the eccentric.
Yep.
Also the anterior mitral valve leaflet. It's a bit thicker.
Yep.
Yeah.
Yep, that's true. And do something here?
Oh yeah, is there a prolapse? It's a prolapse.
Yeah, that's correct.
Moving on.
It's prolapsing, and this is more anteriorly directed. Yes. Okay. And then we check the we get some idea about this one. There is some visa formation, so there is some idea that could be moderate, but we're not sure. We want to check this. It's eccentric, so usual rules will be difficult to apply, but we want to see what it does to the left atrial pressure. So which pulmonary veins we're looking at right now?
So that's left.
Yeah.
No, it is left.
It is left. Yeah, because the angle is around 110 degrees, and we're looking at left. But why I'm getting this waveform? What is this waveform?
That's an interesting one. I was expecting to see systolic flow reversal.
Yes.
But is that what I'm seeing? No.
This is a left atrial appendage waveform.
Oh,
the reason is that many times when we do it in a hurry,
sure.
The left atrial appendage is sitting just adjoining to it.
Okay.
So there's left atrial appendage and the left upper pulmonary veins. They are separated by just a Coumadin ridge.
Yeah.
Okay. And many times you can often place by mistake the probe slightly deeper,
okay.
and you can get this waveform. So once you get this, get rid of it, because go for back to square one, start from scratch again.
Yeah.
And this is what we got. Okay.
Sure.
This is what we got. So what do you think about this of the left atrial pressures? How do you think about S and D waveforms?
I mean, looking at that, I can see S wave.
Yeah.
Is taller. It's still taller than the D wave.
Still taller than the D wave. Perfectly.
Yeah.
So that means that we still have a S dominant pattern. So S and D S waveforms is more than D. That means that left atrial pressures are not elevated. So it will be very hard for me to call this as severe, even moderate. So what we ended up reporting, but Sam would hate, but it was mild to moderate. And same thing we did with the right side pulmonary. It is essential to look for all four. If you're doing a toe, you cannot get away by seeing two pulmonary veins, because as I said, right pulmonary veins you can have just isolated blunting or reversal of right pulmonary veins. So it is essential to make an attempt to look at all four pulmonary veins before you reach a conclusion. So this is a right pulmonary vein, and again the S dominant pattern, which we can see. So we reported as mild tumor. I wanted it was more towards mild, but with the pizza formation, with the color flow looking like that, we reported as a mild. We took an easy way out. The third case is, do you want to have a crack? This is a good one.
78-year-old female, hypoxic respiratory failure, COPD, moderate MR, recent admission for heart failure, loss of follow-up for MVR. Oh dear.
Okay.
Oh God.
Just quickly, mainly I want to know the MR severity and whether the left atrial pressures are elevated or not.
Look, it's a flail mitral valve, P2 segment, severe, and the LA pressures are elevated.
Okay. So do we have a mechanism? So yeah, looking at pulmonary veins, which pulmonary veins we're looking at?
So that's on the left is the left atrial appendage. On the right is the left upper pulmonary vein.
That's correct. That's correct. Exactly. So why initially we use the classic rule, we got the left atrial appendage. So that's why I was telling others that not to get sticky about 110, you can rotate a bit further and then you can get the true flow in.
Yeah. Cool.
Trouser-like appearance is an inverted Y-like appearance. You can get if you can get, that'll be great.
Yeah.
Yep. Looking at left pulmonary veins, and this is the click on this one. These are the right pulmonary veins I'm looking at. So the reason why I put this screenshot of the direction of the jet is anteriorly directed jet. Okay. So this is the right pulmonary veins, which I'll be looking at here. So this is where I'm hoping to get the reversal, the best reversal. The left pulmonary veins may not have reversal. Okay. So let's see what happens in this case. So this is the right pulmonary vein. So I was at short axis view. Then I rotated it further. I could see I used the color box to guide me where the pulmonary veins are entering. And then I could get some flows in there. And this is the waveform I got. Okay. So one is the left, one is the right. And in the inset is the direction of the jet, as you can see. Yes, Rick.
Okay. So the waveform on the left shows a S wave predominant pattern. On the right,
you think this is the? I think this is the S wave. This is the D wave. This is the A reversal.
Oh yeah. Okay. Yep. No, yep. I gotcha. Sorry. Blunting of the S wave. My apologies. And then on the right side, let's see. So it looks like it's going away.
Yep.
On that. So I acknowledging sometimes it's tricky with these patterns. I think it is S wave reversal in the right upper pulmonary vein.
Absolutely. And this is what I want to highlight is, the textbook pictures are great when we get it, but 99%, well, I won't say 99, at least for me, it is majority of times, those things are hard to get. And if we have a mechanism, if you are strongly suspecting the severity, and if you are getting a pattern like this, I would call it as a severe MR. I would call it as a reversal in this case. Okay. And also one interesting thing which was happening here. What is this? We're looking at the intraatrial septum. What do you think is happening?
So you have fixed bowing of the intraatrial septum, and I can't see in this particular view, but if there was a PFO, it appears aneurysmal, which means that it could have a ASD or a PFO underneath. So you could have shunting, although I'd probably go bi-cable, but yeah.
It was a bit tricky, but I'll tell you what we, after a lot of interrogation, that was exactly our initial thoughts, what you said. But after doing a few more interrogations and 5 minutes later, we found out that this septum is basically pushed by the MR jet, which is hitting into that. Yeah. It's just like punching a hole in the wall on like a membrane. That's what it was doing. There was fortunately no PFO or ASD we could found. It does look a bit aneurysmal, but we have to slow down it and measure it, how far it goes in there. Okay. And this is the picture we can see. You can see both, not just a flail, it's also prolapsing. and is the subvalvular apparatus, which we interrogate to see what is the cause of the flail in this case. Okay. And again, we did some 3D, and we can see we're again in the surgeon's view, the anteromitral and the posterior leaflet, and you can see the prolapse of the P1 leaflet. Okay, and similarly an anteriorly directed jet. So aortic valve is at 12 o'clock position. We're looking at the mitral valve, the anteromitral leaflet, moon shepherd, and a crescentic shepherd posterior mitral leaflet. And the jet, as you can see, is hugging the anterior wall of the left atrium and trying to ascend through along the aortic valve. Okay, all right. So another case, Hayden.
Yeah, 74 with right atrial mass, shortness of breath, and fetal edema. Okay. Okay, so that's mid-esophageal 5-chamber. We're looking at the mitral valve again. When there is an MR with, as you said, MR with a small teaser. So I'd like to know a bit more about that, the characteristics of that MR.
And then we interrogate a bit more. So we went into, I don't know why we did that. Oh, this is just the bicaval view. So yeah, that's the pulmonary veins. We did that. And what do you see here? These are again the real life waveforms.
That looks normal to me. Is that S1, S2, and D?
That's correct. Yeah, that's correct. So this is the I'll get my laser pointer. So this is the S wave, D wave, A waves. It's hard to imagine. I can just think that somewhere it exists there. But there's a S predominant pattern. That's the big picture. I don't think the left atrial pressures will be elevated in that case.
Yeah.
So it'll be hard to call me. So I think it was just a mild MR which we were looking at. And similarly, I think same on the right side as well. We examined all the four, and we were all getting this S1, S2 waveforms, D waves. As I said, they're better seen in TOE than in transthoracic. I've never seen S1, S2. Or maybe I didn't know when I saw them before. Eyes can't see what mind doesn't know, right? Okay, so and in that same case, there was another interesting find. He was also referred, as I said, it was written on the stem.
Yeah.
There was a RA mass. What do you think about this thing? There are two structures here. What do you think is going on, and which view we are looking at?
I mean, that looks like a bicaval.
Perfect. Yeah.
Is that a big?
So which one is SVC? Which one is IVC? So this one is coming in as SVC. This is IVC coming at 10 o'clock position.
Yeah.
This is the intraatrial septum. This is the right atrium. So what is the structure at the tip of the joining where the IVC joins the RA?
So that's just prominent, like a eustachian valve, is it?
Perfect. That's a perfect. Well, what about this structure at the base of the SVC? The posterolateral region of the RA.
Isn't that? You're getting at like a crista terminalis.
That's perfect. That is exactly right. So this structure is called a benign variant. It's called a crista terminalis. Although it is, it's an anatomical variant, it is a notorious for developing, is a site for, people developing a flutter or a atrial arrhythmias. So it's something for importance for electrophysiologists to look into. So it was just an interesting case. So I thought I'll put vein, and also had some pulmonary vein analysis in that. This is the last case we will discuss. We are almost out of time. So would you like to see this one?
Sure.
This is a great case. So this is the case which was, I would like to thank Dr. Faraz Pathan for kindly allowing me to present this case. Yes, please.
Provisional female, shortness of breath, outpatient transthoracic, for normal cardiac murmur and auscultation. Okay.
So I just want to tell you, this lady came with shortness of breath, chronic, having for a few months, and had a transthoracic in an outpatient, which was reported as normal, but kept on getting admitted to the hospital, and someone, I think, auscultated, developed, heard some murmur, and they said, okay, let's book another transthoracic with another cardiologist. Maybe another cardiologist was on duty. So yeah, go for it.
So this is a transesophageal echocardiogram. On the left is a kind of off-axis for chamber view. Bit hard to comment on the chamber sizes. I think it's trying to show me just the coaptation of the mitral valve. On the right is a evaluation of the pulmonary veins. You can see in the right lower portion is the left atrial appendage. And I guess the insertion of the left upper pulmonary vein is a bit unusual.
No, this I'm looking at. I'll just interrupt you for a sec. I just clarify what views I have shown. I should have written it before I was asking you. So this is just a four-chamber view.
Yep.
Just mainly, I want you to comment on the size of the RV or an LA. Is there any RV dilatation? And here I'm looking at the bicaval view. And here is the left atrium. It is the right atrium, intra-atrial septum. This is SVC coming here.
Okay. Yep. All right. So I think what we're looking at is although the orientation isn't ideal, the right ventricle does appear at least equally as large, maybe slightly larger than left ventricle. So indicates that there's right ventricular enlargement.
Yep.
Given that this is the bicaval view, on the right is the SVC. And I think there's a coaptation defect that's between the two atria, perhaps? Or a coaptation defect, sorry, a 2D defect, which may be suggestive of ASD.
Yep, that's also possible. Yeah. When they
Or-
intro it, I'll show you a color and what happens here. I'll have a look at this. Great case.
So it's going to the right to left, or left to right shunt. Is it a sinus venosus, ASD? The orientation, it'd be like a pulmonary vein entering the superior vena cava.
Exactly. That is bang on. Yeah, absolutely. Perfect. So that's what was happening in her case. So it was a case of partial anomalous pulmonary vein return with the right-sided pulmonary veins draining into the superior vena cava. And this is what was happening. And this explains the left to right shunt and the preferential RA-RV dilatation, which you can see. So if someone is young and you have RA-RV dilatation, always question what is the mechanism? A normal person is not supposed to have RA-RV dilatation, a young, healthy young girl. And this is what's the pulse wave which they have inserted over there. And this leads to our last slide, basically, is about, what are the pulmonary vein anomalies we can come across. Now, it is usual for the pulmonary veins, to join the left atrium. What if they don't? If they are not, they're returning to another structure, an abnormal structure in a normal pathway, and then returning to the left atrium. So a total anomalous pulmonary venous return, it happens when all the four pulmonary veins, they will fuse in the back to form a kind of a small, a conduit kind of thing. And that will not be entering into LA at all. So all this oxygenated blood is then going via a vertical vein. The vertical vein is going and joining either the SVC, in which case is called the supracardiac TAPVR, which is the most common, accounting for about 50 to 60% of cases. The vertical vein can otherwise go into the coronary sinus, where you can say it as a cardiac TAPVR, or it can drain into the IVC, where it is called the infracardiac TAPVR. The important point is TAPVR cannot exist without a defect in the intra-atrial septum or a VSD, where the oxygenated blood is going into the left side. Otherwise, the baby is not going to survive. He will die in utero. If the baby is surviving and is able to come out to the world and is still making it to 2 to 3 months, that means that there is some pathway where the oxygenated blood is reaching the left side of the body. These babies usually don't thrive well, and they present early with shortness of breath. and and cyanotics fail. So this is cyanotic heart disease. The management of that is usually epoprostenol. Sometimes if that is not big enough, they can do balloon septostomy with that, or ECMO and then surgical correction. If the 4 pulmonary veins, instead of 4, 2 are entering normally and 2 are entering via different pathways like we mentioned, that's a partial anomalous pulmonary vein return. So 2 are entering normally. So there is these people can survive till adulthood and they can present much later. It is not necessary that they will be associated with AST. Most commonly they are, but without AST also they can survive because some oxygenated blood is returning via the left pulmonary veins. The right pulmonary veins again can join the RA, SVC, and the IVC. And based on where they join, there'll be different radiological patterns like a scimitar sign where there'll be a sword-like structure, which is basically a prominent right pulmonary veins entering into the IVC. And there are other patterns, which this is not beyond the scope of this current discussion. But since we were in the topic of pulmonary veins, I thought we'll show you what's anomalous pulmonary vein and this fantastic case, which shows a connection between the right pulmonary veins and the SVC, which was happening here. The right pulmonary veins, instead of joining the left atrium, were joining here. And in this bicaval view, we were seeing that anastomosis over here. All right, so that's pretty much all I had to say on pulmonary veins today, and these were my references. If you guys have any questions, we are happy to answer as best as we can.
That's great. Thanks, Rishi.
All right, then thank you. Thank you very much
Thanks,
for
Rishi.
attending.
Much appreciated. Great.
Thanks to you. Have a good day. Bye.